here. So good morning, everyone. My name is Gloria Ye. I serve as the Director of Clinical Research at the Harvard Osher Center for Integrative Health. Thank you for joining us on this very special election morning. We have a great speaker, Dr. Park, for you this morning. But before I introduce our speaker today, I wanted to provide a couple of announcements from the Osher Center regarding two exciting upcoming events that we have. So let me just share my screen briefly. Okay. Yeah. So the first event is this Friday. So this is Healthy People, Healthy Planet Symposium, Friday, November 8th. This is a free virtual symposium that will feature presentations from experts within our extended Ocean Collaborative Network. The symposium is on the reciprocal relationship between personal and planetary well-being. So we'll have panel conversations on a range of provocative topics, including eco-wellness, blue zone, culinary medicine, the relationship between community health and global sustainability, eco-spirituality, and nature prescriptions, just to name a few of the topics. So I hope you'll join us on Friday. The second upcoming event is our 2024 Osher Network Forum. It's going to be held December 9th and 10th. And we'd like to encourage in-person attendance at the Martin Center, although there will be an online streaming option. So high-tech medicine, soft touch healing, advancing innovation and integrative health. So this forum is really on the intersection of tech and integrative health. So there'll be panel discussions, including issues around bias and health equity, development of innovative technologies in industry around mind-body medicine, and how AI and machine learning might impact integrative health. Just a few of the exciting topics that we'll touch on. So this forum is also free, but you must register to attend. Okay. All right, so and now for this morning's presentation. So just a reminder, if you are seeking CME credit for the session, please send an email to hmsoshercenter@bwh.harvard.edu. And also, please put your questions for the speaker using the Q&A function, the Q&A box, not the chat. You could still use the chat to talk amongst yourselves. And we'll be recording this session, so it'll be made visible on our website. Right. So now to introduce our esteemed speaker, Dr. Elyse Park. So Dr. Park is a professor in psychiatry and medicine at Massachusetts General Hospital, Harvard Medical School. She's the founder of the MGH Health Promotion and Resiliency Intervention Research Center, which is a multidisciplinary center in the departments of both psychiatry and medicine. As a clinical health psychologist and a senior health services research, Dr. Park also serves as the director of research at the Benson Henry Institute for Mind-Body Medicine at MGH. The primary focus of her research is the integration and implementation of resiliency and behavioral interventions into clinical care, healthcare systems, and communities. Her work also focuses on the development and implementation of accessible digital interventions for remote clinical care delivery and clinical research. And she's the creator of the Stress Management and Resiliency Training Relaxation Response Resiliency Program, the SMART 3RP program, which she studied to meet the needs across a wide range of populations and is the focus of her presentation today. So it is my great pleasure to introduce my friend and colleague, Dr. Elyse Park.
Thank you so much. That was really a wonderful introduction, and I am really honored to be here with you all, particularly today. And we're going to walk through really what I would love to do is invite people to ask a lot of questions. We're going to walk through the process of creating an intervention program and how it's applied. Really, I went for breadth versus depth on this presentation because what I want to do is make sure that I acknowledge everyone on the team. This is a team science effort, and a lot of the Osher leadership, Doctors Ye and Wayne, have supported this work of some of the junior faculty, and Dr. Mehta has been a part of it. So I really want to be able to honor everyone's work. I have no disclosures to report. And this is the BHI Resiliency Framework. And just to take you back, I had actually met the founder of the BHI, Dr. Benson, when I was in graduate school. And when the Institute moved over to Mass General Brigham, I was brought on to direct the behavioral research at the time. And one of the things we are trying to do is figure out how to take decades of clinical work and create an evidence-based treatment that was replicable, because the clinicians, the master clinicians that have been doing this work way before anyone else had, were brilliant in their creation, and we needed to figure out how to disseminate it. So our framework, the first thing was, well, what is our framework? And I think the thing that differentiates the BHI work is thinking of resiliency as a response to everyday stressors. There were many clinicians that were there at the time, master clinicians, and I spoke with all of them. They had been really heading up this work, and it was clear that the perspective that the Institute took was different than at the time the original conceptualization of resiliency, which is really more based on acute stressors or trauma. And so it's great that they had that insight, because I think over in recent years, these have been our primary stressors. The chronic everyday living is really what causes long-term emotional and deleterious emotional and physical health outcomes. So our framework looks at resilience in response to everyday stressors. How could you adapt more healthfully to stressors? It encompasses one's ability to maintain adaptive functioning in response to the ongoing chronic stress of daily living. And I know that today is a testament to that, and I wish everybody applies some of these concepts today and really has a focus on what skills can people take on and learn so that they feel better equipped for the day-to-day stressors. This work, the basis of this is the relaxation response, which is a physiological state that was created by Dr. Herbert Benson, who is a cardiologist at Harvard Medical School, and noticed that certain behavior of his patients who were susceptible to stress-related disorders, and felt that it was possible through some work he had done with TM actually to elicit a different state. So our focus is on our work is how, from a patient-centered perspective, do we help individuals learn how to elicit that counter state to the stress response, the relaxation response. The work of this was based on another Harvard physician, Walter Cannon, who had described the flight or fight, and now we add the concept of freeze as a response to ongoing set of physiological changes when someone's exposed to stress. And the stress response, as we know, prepares us for a reaction to a threat, to flee or fight or freeze. But the issue is with modern society is, again and again, we're increasingly living in the stress response. So I think the big aha for this program that most people have is just really understanding how much of their life is in the stress response and how much they could have the ability to take themselves out of that. So this is one of the first things we teach. It's really important to be aware of your stress. So what is stress? Some stress is good. Dr. Ann Webster used to use this analogy of a rubber band. If it's not enough stress, it's too flaccid, but if there's too much stress, it snaps. So the question is, how much stress can people find so that they have that healthy resistance? So on the bottom is the healthy response to stress. The stressor occurs, it's resolved, the individual goes on. The top is the allostatic load. So allostasis is the basis when we have a stressor and we have skills to match that. Allostatic load is the wear and tear that occurs when people's stressors exceed their capacity to cope. And so as we see, when we never come down, when the individual in the allostatic load never comes down to baseline, but continues to be in kind of a more hypervigilant state. Bruce McEwen's work has shown different types of stress response. And one thing we do with patients is try to help them understand what their allostatic load looks like. Some people's go to 0 to 60 where this spike of stressor happens, and then they go very high and then they return. They go very high and they return. Some people respond more like the yellow line here, is that they never quite come to baseline, but they have the same type of response. And then some people who are more in the freeze response just flatline and stop having the ability to really respond to stress. That's what looks more like depression, actually. So that's one of the first the concepts that underlie our program. We also use the diathesis stress dual risk model. So diathesis is the one's vulnerability, either caused by genetic or personal factors. And the diathesis stress model talks about the interaction between one's individual abilities, the diathesis, and the stress they're exposed to, environmental stressors, family stressors. And the interaction of the two determines how helpful someone will be, how resilient they can be, or how vulnerable they will be to physical and emotional illnesses. So we talk a lot about that individual. What is an individual makeup? What are the stressors they respond to, and what does that interplay look like for each individual? The theoretical underpinnings of our model are primarily three. Lazarus and Folkman's transactional model of stress coping, which well aligns with the diathesis stress model, basically talking about the skills someone has, the skills that someone has to combat stress is going to determine the impact of that stress. The post-traumatic growth and growth enhancement was something we brought in that was based on actually work done with cancer patients about the positives and the strengths that one gains from having challenges, so that it's not just that resilience is the ability to really to learn and grow from a negative experience. And then positive psychology, the work of Dr. Martin Seligman, which just focuses on people's strengths about creativity and humor and really living purposefully in a more positive way. And we'll talk about how that's integrated in. So this is the model. One of the first things I did when I got to the Institute is took all of the different manuals that people had. I think at that time we had 20 manuals, and I'm a qualitative researcher, I'm a mixed methods researcher. So we made a chart and saw which constructs mapped onto each other's and tried to figure out what are we teaching in our resiliency processes? What are the cores? And so over time, we distilled it down to this model that we have resiliency skills, we have processes, and the output is resiliency. So the RR under resiliency skills, teaching a plethora of mind-body techniques. We do not teach anyone in particular. We're very individualized, saying for some people, breath awareness works. For some people, it's autogenic training. For some people, it's mindful awareness. For others, it's guided imagery. Find what works for you. We also teach some body-mind techniques such as chair yoga. And each session, we teach different techniques. The CBT is more about stress awareness and management. How do you know when you're stressed? What are the different components? Emotionally, behaviorally, relationally, cognitively? What are those components of stress? And how do you know when you're stressed? And how do you deal with those behaviors that occur? And then the positive psychology skills. So our belief is if we teach people these skills, teach them that skills can be taught, they'll become more aware and better able to manage their stress. And that will enable them to develop adaptive strategies and grow. They'll become more resilient. And similarly, when they're feeling more resilient, they're able to better access these skills. So this is the kind of the crux of the model. This is what our program looks like. It's an intake with 8 weekly sessions. Sometimes when we do research groups, it's 8 sessions. It originally had been 2.5 hour, 12 sessions, but when the model had started decades ago, but for in work that we did to make it more feasible and accessible and insurable, this was the model we developed. So there's 8 sessions. In each session, we introduce a different our elicitation response, starting with breath awareness and a single pointed mantra, and then go to more complex levels of self-empathy. Each session, particularly the first ones, really have a didactic about stress or distress. and it starts to integrate some of those positive psychology growth enhancement experiences. So the first session is an overview of RR and resiliency. The second focuses on the science and really introducing RR strategies and minis. We move into more of a physical state. In three, we have three health behaviors that we work with: recuperative sleep, healthy eating, and physical activity. Session 3, we introduce sleep. Session 4, we do mindful awareness and focus on social support and accessing and utilizing self-support. In session 5, we focus on movement and thoughts and body-mind concepts. In 6, we talk about optimism, adaptive perspectives, and jump into healthy eating. In 7, we talk about positivity, optimism, focus. Part 2, learning to do cognitive restructuring and physical activity. We have healing states of mind in session 8, where we get at more of empathy, creative expression. And then the last session is more about relapse prevention, staying resilient, and humor. So this is our model. And we had published our framework here that I want to show people if they're interested in looking up the model. This talks about our theory and the treatment evaluation. So one of our biggest challenges is, how do we evaluate this work, right? How do we know if we're achieving resiliency? And we spent a tremendous amount of time looking at these different constructs that underlie the theories and the intervention. And we came up with what was called the current experiences scale, which was an updated version of the post-traumatic growth inventory, which differed from the post-traumatic growth inventory in that the post-traumatic growth inventory asked, look back on an experience and reflect. But the current experiences scale asks, how are you doing now? And allows us there to do pre-post changes and also added health behaviors. So the 6 constructs we thought were well aligned with our work: appreciation for life, adaptive perspectives, personal strength, spiritual connectedness, relating to others, and health behaviors. And this is a 23-item scale now that we use. These are the core measures. So one of the challenges that we had also in creating this model from all of these great clinical programs was, how do we make sure we're measuring the same thing? So we developed core measures, and then as people do different studies, they integrate different measures. But this is stress management. We use the MOXA, the PHQ, and the GAD, which are just anxiety and depression, and the Penn State Worry to capture cognitions. The growth enhancement, we use the LOT for optimism. We use the PANIS, usually just the positive affect component. We use the social support scale, interpersonal connectivity scale, and the CAMS mindfulness. And then we ask people how frequently they practice and sustain RR elicitation practice. This is the model I always show people. This is what we started with. This is actually our bigger version of our theoretical model, which gives a little more detail on the types of strategies and things. You can see under adaptive strategies, it lists positive perspectives and healthy behaviors and social connectedness. But this is literally where we started saying, what is our model and how can we capture this? And some of these measures we use, but we have core measures that we use. And I show you this to really illustrate literally the complexity of trying to assess what changes we're making. And what often happens when you're trying to match assessments to a treatment is that sometimes you realize that the treatment needs to be modified because it might not be capturing what you're trying to assess, or vice versa. So I'm going to start with our work on patients. So this is our research to address the changing needs of patients. We'll talk about adaptation work we're doing for a variety of chronic illnesses, treatment mediators, looking at the ingredients, looking at the impact on health outcomes, and using telehealth. So this is the orbit model, which underlies a lot of our work. It was developed by Susan Tchaikovsky, I think I pronounced that right, where it really underlies our work, where we're thinking about how do we have a clinical question that emerges from usually our clinical work or clinical research. What is the preliminary stage? How are we defining and refining our question? And then how do we begin a proof of concept, maybe a single arm trial, do a pilot trial before going out to move into efficacy and effectiveness? And oftentimes, a lot of our work, particularly when we're starting out, and the work that actually the Osher study, the Osher has founded, Institute has founded, is in that phase 2 preliminary testing where you're just developing and refining as you go back. And it might actually push you back into phase 1 where you're defining and redefining the question itself based on the preliminary testing. We've been successful in getting Ks, then moving forward toward the efficacy preparation. So this is an example of work done by Christina Saros and Amelia Stanton, who are focusing on aging women with HIV. They were really looking at rates of anxiety, stigma, sexual decision-making difficulties, isolation, and low levels of social support among women who are HIV positive in their 50s. It's a unique cohort since the treatment of HIV has changed, and so these women often feel even more isolated because of that. So they got an NCCHR 34 to conduct an open pilot to adapt the intervention to the needs of women with HIV and conduct it in open pilot. This is pre-COVID, so the groups were done via telephone. And so they conducted a trial and were looking at feasibility, acceptability, and exploring some outcome measures. This is what they added to the intervention in the yellow. They knew that they had the common concerns for older women with HIV on the left, and the sexuality concerns for something that is unique to their population, well, to their focus of their intervention. So they needed in the didactics to add education around HIV prevention, development of sexuality goals, problem-solving barriers, and more self-compassion, and really more of a focus on depression and anxiety, because they felt that the current intervention skills were helpful, but they needed to double down on those, particularly with this population that's so at risk for that emotional distress. This is a study by Daniel Hall, who is known to all of you as a previous T32 Integrative Medicine Fellow. He was really focused on fear of cancer recurrence, and so did, when he was a fellow, some preliminary work, and then was able to get a K23 mentored by myself and Dr. Ye, looking at the feasibility and acceptability of creating an intervention, really wanting to look at eventually decreasing recurrent severity. We just had a paper, a big recurrence paper was just accepted into Psychosocial Oncology Journal. So he's really done this, he's really taken this work from the phase 1 through the phase 2, and we're thinking about the next steps soon. So this is what his trial looked like. This is what his initial K looked like. He was looking at a mind-body group and group support referral, and was doing a 3-month follow-up. So this is where he published, showing the kind of the variety of work. One of the things that he did that was really important, that we often also do, which is why I picked this slide, is a systematic review prior to his work, so he understood the field of fear of cancer recurrence. And then this is how he changed his intervention, looking at the modifications for his program, focusing the mindful awareness components on uncertainty and reactivity and unpredictability. We have a chart where we ask people to look at their stress warning signs. We ask them, how do they know they're stressed? And we help them identify the different buckets of stress. And so he looked a lot, he focused on the behaviors of looking for to reinforce their fears, like doom scrolling, and then really focused on social support with oncology providers. I'm going to go into the next series of work looking at work that's done with cancer survivors as well, by Giselle Perez, who's a junior faculty member, Zayma Ahmed, and Lucy Finkelstein-Fox, who are junior faculty who received Osher funding to really get them started. So this is Giselle's work. She was doing work with survivors transitioning post-treatment. And so she really talked about social support and communication and exercise and fatigue versus sleepiness. Those are the components that she felt individuals who are transitioning from cancer treatment back into post-treatment needed, and also is very focused on problem solving versus acceptance. We have an exercise toward the end where we teach people about choosing different coping skills. And for these individuals transitioning to cancer treatment, acceptance was a big part, whether it's acceptance with the physical changes, late effects, cognitive changes. And so focusing on acceptance and just emotional awareness and connecting with their body and being able to understand fatigue versus sleepiness. So not just getting enough sleep, but how to identify and accept and treat ongoing fatigue. This is Lucy's work, which she's doing sexual health among female lower GI survivors. And this is exciting. This is for Osher. I'm going to show kind of overview of the results for the first time. She was looking at ingredients for a sexual health intervention for these women. And this is, we just finished wrapping up qualitative piece, and this is actually her model. She did qualitative interviews in 2 pilot groups with women who were treated with lower GI cancer. And so this is her model. She has precipitants of sexual well-being concern, then domains of sexual being, components of the intervention, and the primary clinical outcome, which is satisfaction with life. So her precipitants of sexual well-being are all the different types of treatments and experiences they've had via social stigma, embarrassment, and the challenges of all the treatments. The domains, she's adding body image to ours, avoidance of medical treatments, communication needs with intimate partners, all of those components that are not typically in our intervention, and then using a lot of the bread and butter core intervention components. But the domains of sexual well-being, as you see, there's 6 primary concept structs that have to be added. One of the things I want to say also, it's a challenge, is you can't just add things. So as we created a program with 4 components, we want people to be testing and using the same evidence-based treatment, but we also want to adapt it to the population. So one thing we spend a lot of time talking about is, what do you add versus what do you take out, and keep the same core program with the spirit of that. And that's a challenge. This is work that Zeba Ahmed is starting to do with her Osher pilot, looking at individuals with post-traumatic stress syndrome, and she wants to adapt these skills to individuals with post-traumatic stress. So individuals who don't fit potentially criteria for PTSD, these are non-cancer patients, these are any patients, and develop and evaluate a program through iterative adaptation for these individuals. She just did get a career development award for the American Cancer Society, also focusing on adolescent and young adults. And so this is going to be her model. We've actually started working on this for a while. This is her intervention, refinement, and evaluation. What I showed below is this model that we've been using, which is an adaptation model by Castro and Barrera, where there's adaptation, information gathering, refinement, a pilot trial, refinement, and then efficacy testing. So it's a little bit of a different model. And then she's using 3 components, though, to create her model. Some ingredients from the SMART 3RP, but she's also using the trauma-sensitive mindfulness treatment and CBT for PTSD. This is a really nice collaboration with the PTSD, the CATSD program at Mass General, so that her mentors under care are individuals who have expertise in trauma and then resiliency. And we're really excited to see where this goes. This is work that Rachel Rosen is doing, who is an integrative medicine fellow as well. And Rachel's thinking about mind-body interventions for patients with serious mental illness. And Gloria, Dr. Ye is leading her on this. And first, we're doing a systematic review. What body-mind or mind-body interventions are being done, and what are their outcomes, and what's the intensity, duration, modality, and facilitator for this work. Recently, she's been speaking to people, and we've really been talking about hearing the importance of in-person based interventions for these individuals, versus a lot of our work for scalability has been focused on moving out into the field. And this is work by Tina Liberta, who is also an NCCIHS awardee and a post-integrative medicine fellow, looking at her work with MBCT and really focusing on patients with after coronary events. And she actually started a mindfulness program in the MGH cardiology program for women. She also has done work looking at remote delivered MBCT, mindfulness-based cognitive therapy, for women who have SCAD, which is a type of cardiac event that disproportionately affects healthy young women. And so they also have some fear of recurrence issues similar to cancer survivors, and she's working on that program as well. So treatment mediators. So what do we want to know about constructs that impact it? This is work that was done by a fellow when he was looking at, there are different components. So we have our stress management awareness component, and we have our growth enhancement. So what he did is he did a model looking at factors that impact resiliency and perceived stress. He did a path analysis model looking at depression, anxiety, coping skills, gratitude, positive affect and mindfulness. And what he found is if you see, interestingly, what dropped down in the second model, which is the model he used, sorry, it's a little small, is that depression and anxiety were not strongly on the path, which helped us actually with our, we had kind of always talked about that resilience is not just the absence of depression and anxiety. And I love this study that he was able to do because it really helped us show that resilience is not absence of something, but it's addition of something. And he concluded that gratitude, mindfulness, positive affect, and coping were what was associated with higher resilience. And so that really a model of resilience that included that would be very important. So this is a little more work that was done with Lucy, and she looked at mediators of the SMART 3P among individuals who have who are cancer survivors. We have a program for cancer survivors. She looked at the ability to relax with social tension, with physical tension, accessing social support, mindfulness, worry, and affect. And she felt those were the components of the program that were most salient amongst individuals who were post-cancer treatment. She looked at the strength of change of these constructs, and as you can see, the Cohen's D, 0.4 to 0.4 and up is medium to high, and all of these constructs changed in the direction that would be expected pre-post intervention. These are among people who did the Resiliency Survivorship Program, and she was able to move the needle on the constructs. And this is our program. It's a clinical program. This is an example of how research sometimes informs clinical work. We now run it through the MGH Center for Psychiatry, and it's supported by the Cancer Center, and we bill insurance for it, so people, nobody has to pay out of pocket for this program. And the last one is health outcomes. This is work that Daniel Hall and I have been doing. This is work on Daniel's fear of recurrence, where he was looking at healthcare utilization. So it's important for us to also show what are the outcomes if we change people's resiliency or fear of recurrence or the constructs that we're targeting, the psychosocial constructs that we're improving. How does that, what's the so what in terms of how what it's impacting? And this is showing he's looking at use of oncology visits and primary care medicine and emergency room visits, and also complementary and alternative medicine use. And he is assuming that higher fear of recurrence is associated with more frequent use of this deleterious healthcare utilization. One study that I'm doing that I'm going to show you the healthcare utilization is called, it's NCI funded, it's an R21 called Forward Together, where we're actually intervening with cancer survivors and caregivers at the same time, with the presumption that caregivers, as we know, have high stress needs and need a separate intervention. So we enroll dyads, but the survivors are in a group and caregivers are in a group. And we're looking at the impact of this resiliency group on caregiver healthcare utilization. And so we're looking at EHR data abstraction with survivors, but if you see the bottom is caregivers. And the interesting thing about this, and we're really excited to do more work in this area and partner with individuals, is we don't really know, it's still unknown in the literature what is positive healthcare utilization among survivors after treatment. But what we do know is there's markers of both overutilization and underutilization. So it's kind of a challenging thing to measure because we're not sure, because things can go in both directions. The other thing is, in working with caregivers, who are a very important population to work with, we don't have access to their medical records. So it becomes challenging to measure this via self-report. So this is our work with clinicians and caregivers. I'm going to talk about adapting work for frontline clinicians, digital strategies, treatment moderators, and the simultaneously delivered intervention model. When COVID-19 happened, we sat in a room and the psychiatry head, Mauricio Fava, said, COVID's coming, we need to help our clinicians. So we originally were going to do a program with just physicians, but as you see, we addressed lots of different clinicians and integrated them into our work. We developed, as the pandemic was coming, a program just for frontline clinicians. So we changed the session content, the timing. It was 2 one-hour sessions in 4 weeks. We did clinical supervision twice a week, and we had just a really abbreviated session tool. We did it remote. We eliminated the intake. So we were in crisis mode here, and we were building the plane as we flew it. We had group co-facilitation. Usually we just have one facilitator, but because of everyone was learning Zoom and the program was new, I was literally writing the treatment manual each week before the groups. We needed that, and we tailored it to the needs, what we thought of the clinicians. So we adapted it to what we thought the clinicians were struggling with. We were all learning at the same time. So we changed the content of the manual to focus on work-related stressors, isolation, uncertainty, clinical role transitions, financial and family challenges. And then afterwards, we had asked them in a one sentence, like, what were they thinking about your work? What concerns do you have? And Rachel Vanderkrook, who's a junior faculty member, coded these. And we found that some of the concerns that they had matched what we thought we were adapting the manual to. And this helped us make changes afterwards. It's concerns for themselves and patients and family members, staff, existential concerns about the world, systems level work concerns, and job level concerns. So this is also a good example of qualitative research that can inform our intervention adaptation. We reached in a couple month period, 147 clinicians. We ran 17 groups. We ran them at 6 in the morning for the nurses or 8 at night for physicians. 2/3 attended one session, and once they started attending, most of them attended most sessions. And this is during the pandemic, so we were really happy about that. Our primary outcome was stress coping, that we moved the needle on. And we also improved, if you look at the Cohen's-d resiliency, we decreased emotional distress and had a moderate effect on loneliness, mindfulness, and self-compassion was lower. This is during the pandemic. And then this is the publishing. Louisa Sylvia, who's a colleague of ours, really wanted to do work on, this is the primary outcome, and Louisa Sylvia published some work on treatment moderators. This is the program of caring for caregivers, the R21 that I mentioned, where we're doing a mind-body program for caregivers and survivors. And we're doing it together. So the groups are being run at the same time. We're learning a lot about dyadic recruitment. It's challenging, but we're looking, Lucy Finkelstein-Fox also has a supplement to look at gender differences. So we're looking at the impact of the gender of the survivor and the gender of the caregiver. And this is the technology. What we did was we recorded a video for patients who had gone through our clinical survivor program, and everything was virtual so that we did not require an additional visit. But at each point we have where you see the little, the digit with the hand, we released videos and tried to enroll people using Patient Gateway, asking permission to email them, asking permission to text them, so that we replaced any need for in-person visits. And this is the last piece I'm gonna show. I wanna make sure that I have time for Q&A, but this is our work moving into the community. We're partnering with a grant that I have through the NCCH and R56 with the Federation of Children for Special Needs to adopt a program for parents of children with special needs. We're partnering with senior living facilities to offer in-person, in-group treatments, and with community-based health centers. This is our work with health centers. This is a little different. We are partnering with the Mass League of Community Health Centers. We're working now with we responded to an RFA by HRSA about promoting resilience and mental health among healthcare workers. And so we called this program Be Well Together. They did not like the word resilience. They felt that that was kind of overused. And so we call it Strengthening Well-Being in Our Health Center Workforce. We're very aware that our programs disproportionately attract women. And so we like using words like strength. We try to use words and logos that we think will be appealing to men. And these are our participating health centers throughout Massachusetts. And so we're using, this is a little different. What we're doing is we created a tool called the BEST tool, Bidirectional Engagement Strategy Tool. And we sit down and meet with the health center champions, and they have groups of champions now, wellness champions, and we help them set their resilience agenda. So this is a little different than the role we usually play, bringing in intervention, but we help them create and enhance resources that they have, leverage community resources that they might not be using, and try to give suggestions to making systems changes. And so each week we go over each time we meet with them, we go over the resources, what's tailored for each site, what changes are being made. Prior to launching this, we surveyed all the health centers about what they thought their needs were and interest in resources. and then created a tool for each health center. And we're wrapping that study up in a couple months, and we'll have those results. And then we ask them each time to evaluate. So this is also important when you're integrating into a system resilience programs, whether it's a smart therapy or other programs. What's their plan? How interested are people? When are they rolling it out? What are the barriers, and how is it going, and ongoing monitoring? So we developed a tracking tool for that. So that was a different type of role for us. This is the work that have been done with parents of children with learning and attentional disabilities, an area that I'm particularly interested in. 20% of kids in the US have learning and attentional disabilities. The parents are a vulnerable population. There's a lot of work for parents of children with other disorders, but this seems to be a population that's does not get as much focus. But there are parents whose kids are in schools are struggling a lot on IEPs. And so we created a program and we were able to do a pilot showing that our treatment improved levels of distress, mood, stress coping, mindfulness, and resiliency, and it was maintained at 6 months. We published this. This was kind of internally supported. So this was a waitlist control design, and we found that we were able, through qualitative work, to create a program that was effective for these parents. Rachel Milstein looked at the health behaviors of these individuals and found that parents of children with autism spectrum disorder, which was a separate study we had been doing, or learning and attentional disabilities, reported suboptimal levels of health behaviors. So we had one pilot study with parents of children with LAD, one pilot study going with parents of children with ASD, and compared results across the studies, because in the SMART 3RP, we focus on sleep, healthy eating, and physical activity. And through this post-treatment work, Rachel was able to say, yeah, we really need to increase our focus on this work of health behaviors because these parents do not engage in self-care. So with this, we have funding from the NCCIH. We have a 1-year study. We partnered in this work with the local federation. In our pilot work, we didn't have a partner. This money supports our working with a partner. We're creating in English and Spanish a refined version of our manual adapted for parents. We're doing it for the SMART 3RP and a comparator for the health behavior program. So it's taken us time to establish our relationship with the community. The community members do the recruitment. We spent a lot of time engaging members of the FCSN and parents of adapting our program to meet the needs in English and Spanish in their community. This is a pilot that we're hoping to get, that we conducted and are hoping to get funding for. In doing our work with parents of children with autism spectrum disorder, we found that some of their stressors were for the neurotypical siblings of kids with autism spectrum disorder. So Dr. Kulthau and I enrolled eligible teens, and we ran some groups and published the groups, and we were able via Zoom to have teens participate and practice, and we improved their stress coping. But a lot of them said, we want some more interaction. In our qualitative work from this survey, he said, we want an opportunity to interact more. We liked the Zoom, but it wasn't that exciting. So we're actually proposing to move this into digital space. We're proposing to move this into Discord and do some animations and do work. Discord is an open space that does not require a headset like virtual reality. I actually found out about it from my, at that time, 17-year-old son. So we have this pending, but we're hoping to test this in a digital space. So basically bringing the treatment in for teens where they are, because they spend a lot of time in this digital space. These are our partnerships. We're also pending on a study with Autism Speaks, the autism pilots that we did with parents of kids with autism. We're hoping to develop a program where we test asynchronous, which is what we do via Zoom with a facilitator, versus an asynchronous pre-recorded sessions to see, can we improve the scalability of our program? What is it like if we deliver it in a group with a facilitator versus if we have recordings and we send those out? Can we reach more people and benefit and have some benefit, similar benefit to doing it live? And that's one thing we hope to be able to do. So these are our community partners. It's a lot of, we're writing a paper right now about community partnerships and implementation. We feel like it's where our work should be moving toward. It's a lot of work creating partners and working across communities. It's a work of joy, and we hope we continue to have these opportunities. The last is a arrangement we have, a partnership we've established with Erickson Senior Living. This is our pilot study. We have done work with 4 pilot sites, and we've moved to 8 pilot sites. These are individuals at health centers across the US, residential health centers for older adults, so adults who are 80 plus. And this is work that Dr. Lara Traeger has headed up. It actually came out of the BHI CME course that the head of Erickson came over and said, I'd love to do this for our residents. And so Lara and I flew down to Baltimore, and we created a program that was in-person groups, train their clinicians, and Erickson now has clinicians trained at 20 sites across the US to deliver this program. This was the first pilot. One of the things we're really excited about is if you see of the 9 sessions, the 1 intake plus 8, the great majority of older individuals attended the sessions. We were thrilled with this because we were, quite frankly, weren't sure if much older adults would do this program and stay with it. We made changes. The program's a little longer. Some of them need larger print. We take breaks during the groups, but their clinicians run these groups. And we've had very positive outcomes with improving coping, social isolation, physical symptoms, psychological distress, and positive affect. The one area that we wanted to make a change on, and we're looking at this in future studies because it's really important to show where you don't move the needle, is the community well-being. So in a lot of our implementation studies, like the work we're doing at health centers, we're also looking at community level changes, not just individual level changes. So did they feel that this program improved the well-being of the community? And we weren't able to move the needle on that in this one, but we're hoping we will in future work. So we have to think about a community focus in our work as well. So this is the last slide that we really focused on work by Tyler Vanderweel at Harvard. This is the flourishing program that we're using as a lens for our geriatric patients. We're increasing their resilience, but we're moving toward improving their emotional well-being and their flourishing, which is appropriate developmentally for this patient population. So this is an example of academic partnership where we're looking at resilience, but our partners who are doing this work in flourishing are helping us look beyond that for much older adults. So that is it. I want to thank you, and I'll take any questions, and I appreciate your time on this particularly pivotal day. Thank you.
Thank you so much, Elyse. That was amazing. So much content there. And I really appreciate, the sort of, very systematic approach of developing the Smart 3RP program. And then just the flexibility and the ability to adapt, so nicely, during the pandemic, to shift, on a dime to provide this to providers, but then also just the breadth of your reach to all these different populations and communities. So thank you for that work. So we do have some time for questions, and so I wanted to ask the first question regarding. So I see that your work goes across kind of the research spectrum, and I wondered if a lot of this, do you consider this to be implementation and dissemination work, and what can you say about cost effectiveness?
Okay, so I feel I'm an implementation scientist who I've kind of adapted to that over the years. So I just want to say, I'll get on my soapbox about this. So implementation is meant for primarily once something is effective. Now, that doesn't mean you shouldn't be looking at aspects of implementation, like who you're reaching when you're doing your pilot work, and the time it's taking, and the satisfaction, all of those components. But those are considered what's feasibility. So what's I think a little confusing to people is that the components that measure feasibility, can you do an intervention? Is it going to work? Are sometimes are the same components, but shouldn't be conflated with implementation. What implementation means, I got something that works, kind of like we're doing with Erickson now in our second stages. How do we implement it? So who do we get widespread? How do we deliver it? Are people still going to like it? So, and then we do in my work, actually we don't have any right now wider spread implementation studies. We're writing grants and hope to move to that. I do other effectiveness implementation trials in a different area of my work, which is more health promotion among cancer survivors. And we do cost effectiveness, and that's really important too. if we're able to get that grant funded for what I showed you of parents of children with ASD and looking at asynchronous and synchronous delivery, we do have a cost effectiveness component in that because we do need to see if it's effective, what the cost is of that. But it's really important to think about feasibility versus implementation and moving across the spectrum. And the orbit model that I showed, and I put the response in there, that it comes, the implementation comes with effectiveness at the end.
Yeah. Okay. Thank you so much. Yeah, I do think um, eventually doing some cost analyses. I think some of that came with Daniel Hall's work with the healthcare utilization, for sure. Yeah. All right. So a couple of really interesting questions that came in while you were speaking. So one was, how does a high ACE score, I think that might be adverse childhood events, how does that affect relaxation response treatment success?
How does a high ACE score affect
I
treatment
think
response?
I'm not
Yeah,
100% sure. This came in through one of
yeah,
our audience members, but I think it's about adverse childhood events.
yeah. So I think that's an interesting question. The answer is it depends. I think that that's work hopefully that we'll be doing more in Dr. Zeba's trauma work. All I can say is in general, the more distress at baseline, the more opportunity there is to grow. But that doesn't necessarily mean people have the skills and the this program for people who have AC might need to be also in a treatment for that as well as this resilience work. So I don't know the answer to that. I do know that it's important to measure it, and I know that we want to make sure that we are treating people who have a lot of skills to learn and room to grow. And so folks with that trauma should be able to really make some advances if they're ready. And that's one of the things that we're developing with this treatment with Dr. Zeba that's half resilience and half trauma focused, is that we also have to make sure that we have the setup to properly intervene with that trauma.
Yeah. All right. Uh, this is a question here. So about neurological differences. So are there any neurological differences between people with high resilience and those with low resilience? And if so, does the Smart Therapy program improve these neurological indices?
I'm not I can't answer a I'm sorry, question about that. And I would just encourage you to measure it. I mean, if we could, we are doing the only kind of neurological work we've been doing, and we found some improvement as individuals post-treatment for cancer who have chemo brain, who have some cognitive challenges. And we have found that that increasing resiliency actually decreases the chemo brain effect. That's been done with the work with Michael Parsons, who's a neuro psychologist at Mass General, so I'm happy to connect you with him for that work.
Okay, thank you. So another question that this is around sort of, whole person health that we're talking about these days, right? And multimodal interventions that have so many different components that can potentially, reach these different clinical outcomes for whole person health. And so the Smart 3RP program really strikes me as this multi-dimensional, multi-element intervention. And so one of the questions, taking a couple of the questions that came in, one was about, have you explored fiber arts, as part of this intervention, which is knitting and crocheting and
Yeah,
weaving and hand sewing. And so that's interesting, sort of taking that. But I also wonder, how do you did say that in some ways what you guys teach is a little bit agnostic in terms of the actual technique for the mindfulness, and so how do you decide like what comes in and what goes out, or what do you offer, and how does the actual patient know which one is the one for them?
yeah, it's a great question. So something like knitting and things like that, we would put that under the bucket of creativity, and we encourage people to. We have a pretty expansive definition of creativity. And when we talk about creativity, people say, "I can't draw," and we say, "No, no, no, it's not. It's about baking or playing with your children, or knitting is wonderful." Or knitting is also known to elicit the RR. So how do we know if it's working is we encourage people, and we try to one of the things that we're really working on is getting documentation, how much they practice. So what we say to people is each week we introduce different RR elicitation strategies, and we give audio links, and we ask people to practice, and they make that determination what works for them, or if there's other kinds of RR that elicitation that works for them. So how do they know is they do the work. They do the between session practice. They document it. What we know is more documentation begets more practice, begets more improvement. And that's really there. And then in the sessions, they come in, they talk about where they saw changes, and really importantly, how to integrate that into their daily life, because we know the more integrated, the more likely people are to practice and the more successful.
So there's a few questions about just, I guess, pragmatics is how and where is the Smart 3RP says textbook. I don't know if or their manual potentially is where is that available? Is it available in Europe? And also, is the Orbit publicly available?
So the Orbit's publicly available. There's that Tchaikovsky reference in 2015. There's lots of articles that show the Orbit model. Our manual is not publicly available. People can sign up on the BHI website for training to be a smart practitioner. Patients and people who are training get the manual. And it is being done through this training. I just came back from France. We are working on translating it into French. It has been translated to Spanish and a few other languages. And we're hoping to get to develop more studies where we're doing some linguistic and cultural adaptation.
Yeah,
but if anyone's interested in Paris, the program is being done in Paris, and I can give you that contact.
Okay, wonderful. We do have maybe let's see if we can get in a couple more. I see actually some came in the chat. I wasn't looking at the chat, so
I answered a couple in the chat. Kristen asked about we recommend for some groups booster sessions where people practice their skills. Yep.
Great. Okay.
Victims of domestic violence. It's similar. I have to say this is similar to the question you had with ACEs. Are very careful. We're working with colleagues who do trauma work at Mass General at the Katz Center, and we're really trying to figure out how to treat patients with trauma and what's the right course, whether it's trauma work first and then smart or smart trauma informed. So we're working on that, and it depends. What we do when we do intakes for clinical work is really assess people's level of trauma and whether a group treatment is good for them. One thing Zeba really wants to try in her work, and through her Osher funding and now the American Cancer Society funding, is really see if you could do kind of trauma-informed care in a group. But I have to say that's not primary trauma. We're not working with people with PTSD. We're working with people who have post-traumatic symptoms, stress symptoms, or secondary trauma. Yeah. But I would not recommend, let me just be clear, I would not recommend the Smart 3RP as the first line treatment for untreated trauma.
Okay. There's one that came in earlier. How often might you see allostatic in the diathesis stress models change throughout an individual's life? Can you speak briefly to that? It's the last question.
I think it depends. The diathesis stress model says, it's about your environmental stress and what your personal kind of vulnerabilities are. And so I think over time, though, skills like through the Smart 3RP improve people's dispositions. But I think it would. My sense is that people's diathesis, the diathesis stress presentation, the allostatic load, varies on throughout life in terms of the stressors they encounter and the skills they have to combat those stressors. So I think it's an ongoing experience. We hope that the Smart 3RP helps give people skills to start that the improving decrease, their balance, their bringing down their allostatic load so they can hit a level of allostasis or a comfortable level of allostatic load for themselves, and really helps people in this process of continuing to combat stressors. But as we see, the last thing is we're doing this model with and program with people at all developmental stages. And I think each stage has different stressors, and we need to be adapting and treating skills for each stage.
So thank you so much, Dr. Park, for this incredible work and for this program
Thank
that's
you so
that's
much.
really out there helping people. So thank you so much. In just one more minute, I'm just going to share my screen. I just have a few additional announcements for the Osher Center. Uh, So here, just to tell everyone to please join us next month, December 3rd, for our next grand rounds with Dr. Claudia Witt. She's professor of medicine at the University of Zurich. And as a perfect lead-in for our Osher Network Forum for the following week, Dr. Witt will also be speaking on AI and healthcare opportunities and challenges for integrative medicine. And this is just a reminder for our Osher pilot grant program, which funds projects in integrative medicine and health, including basic translational and clinical research, awards of 25 to 50,000 each, and the letter of intent is due January 15th. And you can check our website for further dates of this process. And then finally, I just want to say that the Center can't do this work without support. So towards the end of the year, if you're looking to make your 2024 charitable gifts, we hope you might consider the Osher Center, and you can make a donation on our website. So thank you for your support. And with that, I close today and thank again our speaker, Dr. Elyse Park. And I wish you all well for the rest of the day. Thank you and take care, everyone.